Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. I'm going to start by saying that I am really looking forward to this episode because today I have the pleasure of talking with a world-renowned oral surgeon, Dr. David Alfi. Dr. Alfi is from Los Angeles, California, and he attended Columbia University for dental school and his residency training in oral surgery. Following his residency, Dr. Alfi joined Houston Methodist and Texas Children's Hospital while working as an associate professor and full-scope surgeon. Dr. Alfi then started his own private practice in Houston, Texas, with the vision to excel in surgical outcomes and advance the field with research and development of surgical techniques. And he is certainly doing just that. His work is truly amazing. Many of you may have seen some of his work on Instagram, and we'll talk a little bit about that. And he has patients traveling to see him from around the country to be treated by him and take advantage of his expertise. He also trains other doctors through fellowship programs and continues to give back to the profession to make it stronger, which I absolutely love. So with that, I would like to extend a warm welcome to Dr. David Alfi to the Doc Podcast. Welcome to the show, David.
Thank you so much. Thank you for that really nice intro.
No, you're welcome. I mean it. I'm really excited for this. When we first met a little while back and started talking, I mentioned that we have some commonality here with, I had family that went to Columbia. My dad, his three brothers, and their dad, my grandfather, all were Columbia dental grads. And then my grandfather and one of my uncles went to Columbia for oral surgery as well. So it is a small world in this dental arena.
It is. Yeah. That Columbia family is really a strong family.
Yeah, absolutely. It's a close-knit group. So, but first, on that note, talk a little bit about, if you don't mind, your journey, just what got you into this field. I love hearing about people's backgrounds. Everyone sees where someone's at now, and you're a world-renowned guy and you've got a big name, but we don't all start there. So tell us a little bit more about how you got to this point.
No, that's true. And I'll be candid with this story because I think it fits into your audience and you as an orthodontist, because my initial desire to get into dentistry happened when I was in middle school.
Okay.
And I was seeing an orthodontist for my class 2 malocclusion. And that's another story about airway and all that.
Uh-huh.
But, and we'll get into that. He wanted to remove my upper premolars to set back my anterior maxillary teeth to compensate for the overbite. My mother at the time denied the treatment.
Really? Even back then, before that was common?
Yeah. What's interesting is that I was happy because I didn't want any teeth removed at that age. I was happy with the way I was. I didn't care about my overbite at the time. But I talked to her recently about that decision and told her that I was very thankful that she declined the removal of those teeth. And I'm afraid that had that happened, I would have a much different face and a much worse airway.
Wow.
Had she done it. And I was very pleased. And she said, you don't know how happy that makes me, because that decision haunted me to this day. If
really
question whether or not she did the right thing because she went against the doctor's advice. I told her I was very thankful that she made that decision.
Wow. That is, and you'd never really talked to her about it.
Never talked to her about it. Yeah.
That's crazy. Well, that's some relief for her. And did you ever end up getting treatment? I mean, did you edit for orthodontic later on?
So we finished with a class 2, and then I'm in Invisalign now.
Okay.
Just expanding the arches a little more. If I could do surgery on myself tomorrow, I would do it.
I was literally thinking to myself, I was like, with your ability, you probably figure out a way to do it on yourself. But that one, you talk about some hits on Instagram. You get that one done.
And I'm doing it for my brother on Monday, actually.
Are you really?
Yeah, my brother Johnny. So.
And then did you know? So once you're thinking ortho, you stayed on that path, dental school. Did you know? At what point did you realize that? Because I was very similar. I thought ortho all along from 8th grade. And then when I got to dental school, I actually started thinking, well, maybe surgery, maybe do GP with implant focus, because that was big in the 90s. The implants were starting. And then I just saw an orthodontic office and fell in love with it, and the rest is history. But so how did you have your change?
So the funny thing is, this is why I brought up the story. You may appreciate it. So I didn't have no one in my family was ever in medicine. I had some engineers and businessmen. But when I was in ortho, I remember the orthodontist had a Movado watch, which I thought was a cool watch at that age.
Sure.
And he had the assistants doing all the work for him. I remember him just popping in and out. And I remember that it was very hard to lock down visit dates because he was always in the Caribbeans.
Yeah.
And I'm not joking. At that age, at 12 or 13, I said, I'm going to be like this guy.
Sounds good. Yep.
This sounds like a good life. And that decision alone carried me all the way to dental school. So I went from middle school to high school, college, just knowing I'm going to be a dentist and be an orthodontist because of how this guy had a life hack for his career. And then I got into dental school at Columbia. And with Columbia, they're integrated with the medicine early on in the first 2 years. And the oral surgery department has a huge influence on the training, at least at that time, for the dental students. And I fell in love with medicine and learning and health. And I fell in love with surgery, and specifically oral surgery and orthognathic surgery, while I was in dental school. So I shifted gears. And now I tell people I do all the work myself. Now I travel, but for a long time I never traveled, and I work a lot. So,
like, what the heck happened to this dream?
The opposite of what my middle school version of this ended up being. But now I'm so happy. I don't see it as work at all. I just feel like I'm having fun.
Isn't that funny how that changes? And it's funny. So you probably would have been unfulfilled if you went the orthodontic route, right? I mean, how life changes based on what you're doing now, and maybe not, but I think there's just all those, I'm big on the fact that there's signs and people and things that happen to all of us along our journey. Yeah. That you may not realize it at the time, but it's all part of a greater plan. And you think of how many people you have helped and the lives you have changed. And if you had gone a different path, not that you couldn't be helping them in a different capacity, but you certainly wouldn't. Yeah, it's just different. So I love that.
I do think it's all meant to be.
I agree. I completely agree. It's a lot that's beyond our control, and our jobs to just try to read those signs and stay on course and do the best we can do. I tell that to the residents and people I coach all the time.
Yeah, absolutely.
And so you get in, you're doing oral surgery, you're loving it. You end up heading down south. How did you figure out your path because you have an academic inclination for sure. Teaching certainly is something you're very gifted at as well. How did you figure out you want to do this private practice thing? And you still do, obviously, the teaching side as well. So how did that come to be?
Yeah. So when I left Columbia, I knew that I wanted to be an orthognathic surgeon.
Okay.
And I know we'll talk about airway shortly.
Yeah.
It's not something we learned at the time, but I knew I loved orthognathic surgery for the transformations. So my definition of the surgery has completely changed. Philosophy has changed, and technique and all that has changed. But fundamentally, it's something I really enjoyed. And I knew that Houston was a really great place to be an orthognathic surgeon at that time. It's a large city, a lot of demand, not that many people doing it at the time, but also the medical center was such a unique place because virtual surgical planning was born here. And when I graduated in 2012 from surgery program, it was in its infancy, really. We were early adopters at Columbia of virtual surgical planning, and I was interested in it. So really came here to learn it, understand it, and have an orthognathic practice. So I joined Houston Methodist, which was really an academic type of practice. And we had the UT residents rotate with us, oral surgery residents, and I really enjoyed it. I loved the teaching. I feel like I learned so much teaching residents, learned so much myself.
I agree with that 100%, by the way.
Right.
Yeah.
I mean, they hold you, when you're teaching, you have to hold yourself to a higher standard. Keeps you on your toes.
Yep. Without a doubt. Yep.
I'm sure you're like me, where you want to be prepared for everything. You want to be the expert.
Yep.
So I think it made me a better person, made me who I was, or who I became.
I agree. Yep.
So I was there for 9 years, had a really fast growing practice, evolved in a lot of ways as a surgeon. And it comes to a point in academic medicine where it's not really structured to meet the demands of a growing practice. Mm-hmm. At least it's not their absolute mission.
Yep.
So the support system really, I think, is limited in that sense to be able to serve patients the way I wanted to serve patients and have the freedom to do the things I wanted to do and develop and evolve and grow. So at that point, I could feel the stress on the system. Mm. And I feel like it was holding my vision back, and making a move to private practice made sense. But at the same time, I was being here 9 years and establishing all those connections and teaching. It was nice for me to keep everything I enjoyed from the academic space, meaning writing, which I still do, teaching, which we started the fellowship as soon as I got here, and continuing to lecture at residency programs and conferences and universities. So I feel like now I have really the best of both worlds and the ability to be in academics, but also grow without handcuffs.
That's actually, it's interesting you say that, because I want to go into that a little bit more. It's something I'm passionate about, and that is the divide, this rift between academia and private practice. And you bridge that gap. I bridge that gap when I'm less in the private practice side, now more in the academia side. But when I was the years of my almost two decades of private practice, I was teaching in faculty at multiple universities on a cleft craniofacial team. So I always loved that duality. I find, though, that it tends to be one or the other for most people. And there's this battle that goes on between basically the clinicians, or the wet-fingered clinician doing it, and the academic institution. And it creates this situation where I hear residents of all types of residents of any dental or even medical specialties, they say, yeah, I'm just doing this to get my degree so I can learn what I need to learn when I get out there. And it saddens me so much to hear that, because the time, the money, the energy, the resources, just to get the piece of paper to let you go feel like that's when you learn. And I know it's a little bit hyperbolic, because obviously they're learning foundations and the fundamentals that let them do this, period. But they're saying basically, I don't know how to really apply this in the real world. And so what are your thoughts on, being that you've been intimately involved in both as well, how do we bridge that gap going forward? Because I really feel that's a big thing for our professions.
Yeah, I agree. I think that it's interesting that there's a divide. For the most part, what you're doing and what I'm doing is very unique. There's not a lot of players that are involved with both. Mm-hmm. And I think that is the issue. I think that there are reasons, and some of them I could identify, that keep the academic people really in contrast to the private world. You know, the institutions and their non-compete clauses and all those things being one issue, closing that system down, the egos involved with those decisions. Like, the fact is that the academic guys are respected heavily in their system, but they're not compensated anywhere in the real world relative to the private guys. And that's going to hurt the ego. I don't know about hurt, but it's going to come in play.
Mm-hmm. Sure.
There's going to be some resentment there for that. And there's many more reasons that keep that divide away from each other. But what happens is, you're right, there's a huge discrepancy between the real world and what's happening and being taught in the academic institutions, because there's such a divide. Mm-hmm. I see it from the fellows that I teach. When they come here, their mind is blown, like, wow, this is nothing like what I learned.
I see the same thing when I rotate through my practice. Same. Yep.
This makes so much sense. Why didn't I learn these things?
Yep.
It's interesting. So there's a huge opportunity lost, for sure, not only for the doctors, but for the patients too. Because you have some pioneers, which are the clinicians, really are for the most part pioneers. And I think that's counterintuitive for what people think about medicine. I think that it's the guys that are out there and wet and operating that are really at the forefront of development and cutting edge technique. And the academic sectors are really what you would think to be ahead of the curve, but there's so much tradition and there's so much handcuffs that the reality is not that.
Yep. Yeah. And the system is set up for failure with insurance and the way the billing gets and the money and the accreditation. And I mean, it's so deep, and it's something that we have to keep working on as a profession. It's going to take time. And one of the things I've found, which it sounds like you're doing too, that's been really helpful. Actually, not long before this, we hopped on to record, I got an amazing email from a resident, not even, I teach at Nova, but this was from a resident. I teach residents around the country and do guest lectures for them, and I coach them, and got a resident who emailed me a case of a 9-year-old, which you just don't learn in orthodontic residencies much about what to do on a 9-year-old, especially if they don't have a crossbite. So it's a lot of what I teach and what I show and how we can look at airway. Sent me a workup of a 9-year-old patient and nailed it. I mean, David, nailed it. Had the transverse deficiency, had the most would just look crowding, moderate to severe crowding, and then like, well, can we do this without pulling teeth, or maybe we try to hold the space? And I teach the difference and what you have to look at. And I've been, teaching and coaching this individual. And I mean, he nailed it. I said, I'm like a proud parent when he said this. It was like, he sent me this workup. He had a cone beam. He understood. He saw the hypertrophy of the turbinates. He saw he saw the enlarged adenoids. He saw the narrowing of the oropharyngeal airway, the lack of tongue space, the dark circles under the eyes, the Denny Morgan lines. He did a history, found out they have severe dust allergy and pollen allergy, is going to work with the allergist and the ENT. And this is all what I teach. Right. And I was like, oh my gosh. He's like, can you help me through anything? Did I miss anything? And I'm like, man, you nailed it. Like, that is it. And so now we'll talk about the right plan and what we do for this patient. Right. But it's so refreshing to see these younger docs. So I think that's the point in that story is, yes, we can go from top down and try to reform some of these institutions. But as you said, it's so deep and it's so complex that one of the things I'm trying to do is this grassroots, tell as many and teach as many young docs about a different way of thinking while they're still in that open-minded learning mentality. And as I've heard you say before in some other interviews and content you've done, and as I've said too, once you see this, and we'll start to talk about this now, the airway side and the fact that the teeth are just the symptom, you can't unsee it. And I have found that the residents really get it and they really understand it. I don't know if you found a similar thing, but
100%. It's really interesting. I'll give a lot of lectures to residency programs and different institutions, and I can feel what the faculty are seeing as I walk out of the room.
Same. Yep.
When I lecture.
Know that feeling well. Yep.
Yeah, but the residents get it. And they're open to it and they're excited about it. And they're like, hold up, like, I want to know more about this.
Yep.
And it is interesting. It's like, it's really just an open mind. And when does that mind close for some people is an interesting question.
Yep. That's a great question.
You're right. It's like, it's so obvious.
Yeah. It's almost, when you said that, they said, why aren't we learning this? And I've had residents express to me anger. Literally, they've just said, this is so clear. And why? And not only anger, they're not learning it. Even more than that, anger that our profession is resisting this, that we are fighting to not do this. And so on that, I know being an oral surgery ortho, we work very closely together. What got you thinking differently about airway? What was was it an epiphany? Was it a certain case, or was it just gradually looking at results of surgeries you'd done? I mean, how did you go through that mind shift? Because there weren't a lot of people back 10, 15 years ago when I was going through it on my side. It wasn't as commonplace. You weren't hearing about it, and we all have our stories. So what was your journey along the airway process?
Yeah, the biggest thing, it's been really a gradual discovery process. Doing it, I'm 13 years in practice now. And I didn't learn any of this just because it's nowhere to be found. Nope. It still isn't. Yep. It's getting there, but it's still way behind. But definitely at that time, there was nothing like it. Mm-hmm. But at the same time, there was a lot of information there for us to open our eyes to. For example, I was seeing severe sleep apnea patients where we did do MMA for sleep apnea. But at the time, those were looked at as last resort, terrible procedures. So we did few, but in those few that
meaning like you try CPAP first, you try mandibular advancement splint, you try like all that first, and then okay, yep.
Yeah, and they tried UPPP and
yep.
turbinectomies and everything they can get. Base of tongue reduction. That's the way it was. And in those cases where they were desperate and they came to the medical center when I'm doing orthognathic, and I got maybe a handful of patients a year early on in my career with those cases, it was like one by one, like, wow, their life's changed. Mm-hmm. And then then we were doing mandibular appliances, advancement devices mm-hmm. for people, and that was taught. Mm-hmm. Yeah. But it's like, why are we doing that? It's just moving the jaw forward. Mm-hmm. So wouldn't it make sense to move both jaws forward? So it's like the data is there.
Yeah.
And it's obvious, but for some reason it was not taught. And I think part of that was that it was such a difficult procedure for patients to go through and for surgeons to complete with success, meaning no relapse, good healing, a decent recovery. It was honestly the traditional methods. It's not true. It was a tough surgery, and I would talk people out of it for the most part. But now it's a different operation. I think that's part of it. Mm-hmm. You know, an hour.
Yeah, talk a little bit about that, because I mean, I'm not saying this to overstate it with you. You are extremely talented in this arena, and you deserve credit for that. You're a pioneer in this. So tell people, you're welcome. Tell people what you're doing and how it's different. If I'm not mistaken, you're doing a couple hundred of these a year. I think what most would say, 50 would probably be a really high number for most people in that arena. What's that?
I'll do about 220 doubles this year.
Yeah, I mean, that's just astonishing. So talk a little bit about your technique, how you're doing, how long they're taking. You would talk about them being less invasive and minimally invasive. Just talk a little bit about that, if you would, for people who aren't familiar with what you're doing.
Yeah. So like I said, when I started my career, I was early adopter into the virtual surgical planning, which is now standard. Mm-hmm. We used to do model surgery when I was a resident.
Yeah.
I remember that practice. Do basically plaster stone models, cut the models, move them, make splants. So right when I started, I went straight to virtual planning. And I was always obsessed with not being stuck in my ways. And because I looked at my attendings who were behind the times, meaning as a resident, when I knew more than them, I really looked down at that. And I wanted to make sure that I was never that dinosaur in that sense. That was something that it just really was off-putting to see a surgeon that wasn't at the top of technology and technique. So almost to an opposition to that, I always, even to this day, look for what can I do better? What makes sense? What are we doing that doesn't make sense? What's the new technology that we can apply? What is everybody else doing that's new? Now, I'm still obsessed with that process, but I was obsessed with that process from early in my career. And when I got exposed to custom printed titanium guides and plates for cancer reconstruction, being in the medical center, I thought that this would be something that we can utilize in jaw surgery. And I remember about 5-6 years ago applying it at a time when nobody did it for jaw surgery and did full custom upper lower chin with custom guides and plates that we were really just figuring out that we can use it. And it was such a success, and I never looked back. And it's been over 5 years now that every case, it's been almost an evolution of developing designs, techniques, protocols, and using that technology, taking the surgery down from what I used to take 4, 6, 8 hours to now on average, I would say double jaws under 60 minutes.
Wow. Man, that's
average.
Amazing. Wow.
Yeah. And we've done one in as little as 39 minutes closed.
Oh, unbelievable.
Yeah. So a different operation.
Completely. And the healing and the morbidity. And my goodness, it's just got to be exponentially different for these patients.
So different. And I'll tell patients, expect to go back to work in 1 to 2 weeks.
Wow.
And most of them do. And I've had many dentists and surgeons go back to see patients 1 to 2 weeks after surgery. My brother says he'll be back here after 3 days. We'll see. But really, it's a different recovery process, because the trauma of an 8-hour, 6-hour versus a 1 hour is completely different. And the tissue response is different. The recovery is different. So what we're using really is, instead of using the information from a acrylic splint to wire the mouth shut and then bend plates and measure in the operating room. The transfer of information is directly at the bone with the custom printed guides and plates. So things
so the traditional way, for those, because I have some lay persons who listen to the show as well, where, and correct me if I misstate this, but that the traditional way where you release the bone, get the teeth to fit together in a splint, wire them together, and then retrofit the plates in to secure the bone segments. You're saying you use the bones, you almost do a 180 of that, where you let the bone segments under the custom printed titanium plates guide the surgical movement. Am I saying that correctly?
Yeah, exactly. Because in the traditional sense, in both traditional and custom, the plan is done on a computer. But in the traditional sense, people are transferring that information backwards. They're using an acrylic splint, wiring the mouth shut, then bending the plates to try to get what they're getting on the computer. With the custom, the plate actually transfers that information. So instead of bending a plate to the bone, we're moving the bone to the plate. So it is a 180. But by doing that, I don't have to put a splint. I don't have to wire. I don't have to unwire. I don't have to measure. And I don't have to bend. And you can imagine for each step that I don't have to do those 5 things. It makes sense that it's going to be a lot more efficient.
Got it. So now, are your incisions much different than what they were?
They're pretty similar, not much different, except for what we used, like for an inverted L osteotomy for a very large movement. Traditionally, those have to be an extra cutaneous, a skin incision on the outside to expose that. Now I could do it all inside the mouth because of the titanium guides and plates. So for those cases, we can avoid external incisions and scars and do it more minimally invasive. But for the routine double jaw surgery, the incisions are fairly similar, but the process is much more efficient. And then more than the timing and efficiency, which is still important for bleeding, recovery, infection, all those things, the process is it's so much more accurate because there's less room for error and transfer from something that's indirect to something that's direct. So I don't rely on elastics after surgery. The traditional sense, we always used to have to put braces on, put surgical hooks, put elastics. And the reason for that is because nobody got what they were planning to get. And
right.
Right. And that's the truth. I mean, I don't think any surgeon will deny that.
Or orthodontist. Agreed.
Or orthodontist. That's the truth. But now it's so accurate that I don't like braces. I prefer Invisalign with no buttons or screws or anything. We're just going to get it right. And then 6 weeks after, I'll send the patient back to the orthodontist, and then it's just an ortho case. And I tell some orthodontists who are not familiar with this, like, let me just give it back to you in 6 weeks, and don't even think of it as a surgery case. Think of it as a liner case, and then scan them and finish it. That's the reality of it.
Because you've normalized the anatomy, the structural anatomy. Now, how did you figure out the airway side piece of this? Was that something that you just noticed these patients? Because, I guess first I should say, talk a little bit about the magnitude of these movements, because they're mind blowing and they defy a lot of the stability. And I'm going to make a little bit of a flip comment here, and I don't mean it to come out wrong. And my audience who knows me knows why I'm saying this. But you didn't have any double-blinded, randomized controlled trials telling you that you could do this. I mean, this isn't the standard of care, David. I mean, come on. So sorry, I couldn't resist. But
I get that. I got that yesterday on Instagram.
Of course, I get it all the time with how I've pushed the envelope in this arena on the orthodontic side. So I apologize for the editorialization there, but I couldn't resist because
it's really the same. This is what most people don't understand. It's the same. We're doing the same thing. We're using titanium. I'm planning on a computer. It's just more precise.
Yeah. And that's where innovation comes from, the fringe, from people like you who are pushing this. You're using science and data and knowledge, but you're just applying it differently. It's the Peter Attia concept, right? Of medicine 2.0 versus 3.0 and going to an evidence-informed, and that's an evidence-informed decision you're making. You're looking at all the evidence and the data, the literature, the science, the biology, et cetera, and you're applying that to get a better outcome. And I say that all the time when I teach people on my concepts and approach to doing things. It's just knowing the biology, and you're not doing anything outside of the normalization of anatomy we're all trying to do anyway. You're just doing it more efficient. Right.
Better than I learned it.
Right. And the the benefits to the patients are just unbelievable. And so, so the magnitudes of the movement that you're getting, and then the stability and how that's playing out.
That's a great point, and it's directly related to your airway question, because the reason we didn't like MMAs is that these large movements that are required to come forward to open up an airway, traditionally they said 10 and 10. Mm-hmm. On the top on a straightforward movement. I do it differently now, but that's a large movement to make. And when you have traditional plates and technology and you're wiring things shut and trying to force this thing down, and you don't have the information you have with a custom plate, because what I mean by that is it's actually much easier to complete a case with non-custom in a sense, not the right place, but just to finish a case. Because what happens is once you make your cuts, and if your tissue if your bone has interference or your tissue has tension as a surgeon, you may not even know it, because you don't have a custom plate telling you that you're not where you are, because you just wire it shut, and then you hold the segment and you're like, okay, that's where it must be.
Right.
And you just take it because you're bending the plate to that position.
Yep.
So in a lot of sense, it's much easier to fudge. But the problem with fudging in the traditional sense, which is what by definition everyone has to do, because they don't have the information at the bone level to know if their movement was large enough, or if the tissue envelope is restricting that, or if there's bone interference. That's why I think a lot of people got relapse, especially with the bigger movements, because they actually didn't get what they were planning to get, and they wouldn't know that until the patient wakes up.
Okay.
So with the custom, I know that if I'm moving 20 millimeters, and until my plate tells me I'm in the right place, I do more work to relieve tension, find the interference, and get to the right place.
Okay. Got it. Yep.
So by doing that, we're not seeing the relapse. We're not seeing the poor execution or instability, because in that operating room, the plate itself not only gets it faster, but when it's used right, it gives me the information to know that I did what I planned, and I didn't just bend the plate to think I planned.
Got it. Okay.
So there's information built into there, which gives you a surgery that's now more efficient, predictable, better recovery, but also is without relapse, or what I think relapse in most cases is just you didn't get what you tried to get. Right?
Yep.
So we're getting what we want to get. And now the treatment planning is completely different, because when I was in residency, if someone had a 10 millimeter discrepancy, like an underbite, the attending would say, just bring the mandible forward, bring the mandible back.
Split the difference. Completely.
Right?
Yep.
The reason, not because the maxilla didn't need to come forward 10, but just because it was an easier operation.
Yep.
Because of those reasons.
Yep.
So you can't fix the airway if you're splitting the difference or you're compromising. Yeah. Philosophically, it's it's not even in the conversation. But now that I know I can get 20, 25, 30 millimeters at Pagonion consistently with no relapse, with stability, now that split the difference, field goal, compromise philosophy is different when I'm planning, and I can look at a skeleton and say, that Pagonion's 20 millimeters behind, I'm going to bring it forward 20 millimeters. There's no reason to go for the field goal when the quarterback can get me into the end zone, right? Like I have the tools to get into the end zone. So I'm going to plan it to 20. So now we can look at airway, because we can make those 10, 20 movements and get there predictably. And I think for me, that thinking about it that way is one of the key reasons I started to appreciate airway, because I knew I could get there.
And did you have patients that were telling you, and were you having patients come in who were looking for an MMA, you knew they had an airway problem based on referral, and you were starting to see your results in the surgeries improve? Or was it that these were patients that you didn't realize the changes you were making in the airway until they were post-op a couple of weeks or months, saying, geez, Dr. Alfi, is it a coincidence? I mean, how did that come to be?
Yeah, a little bit of both, but not in the straight sense of coincidence.
Mm-hmm.
There was the pocket that were definitely, this guy needs MMA. He's tried everything else.
Mm-hmm.
He's a pilot. He's grounded from flight.
Mm-hmm.
I remember having that patient early on, or I remember my first year, a patient with cerebral palsy that had debilitating anxiety and such severe retrognathia that I did a large advancement for. And one by one, like that cerebral palsy patient, her anxiety improved significantly. I mean, it was a change for the entire family and the people supporting her. And the pilot, his life changed significantly. And it's like one by one, those that were coming for it were getting better. And then at the same time, I'm doing mandibular advancement splints. And even though that lower jaw is coming forward a little bit, some people were exhibiting improvements in their quality of life just from that.
Mm-hmm.
And you start to put these things together. And then there were patients where now I wasn't necessarily thinking them as airway patients,
mm-hmm.
but they were retrognathic, and now I'm getting more confident putting them forward 20.
Mm-hmm.
And then I'm hearing my anxiety's gone, my headaches are gone, my TMJs are better,
mm-hmm.
I'm sleeping better. And then at some point, it's like a big light bulb, and it's like, wow, actually, there's no MMA versus orthognathics anymore in my mind. Every case is an airway case.
Yeah.
Every single one.
Isn't that amazing?
And then, and then you just go down the rabbit hole and start learning about what happened to our skulls over the last thousands of years. And why are we taking out wisdom teeth on everybody and not questioning why don't we have room for wisdom teeth?
Mm-hmm.
Why is everybody crowded and narrow and all these things? And it's just like, how obvious is that?
I know. And I fight this fight all the time, David, because there's a lot of my orthodontic colleagues who still stand by and they come at me and say the etiology of malocclusion is entirely genetic. There's nothing more. I mean, Melvin Moss, where you went with the functional matrix theory, and you know, he actually was a professor when my dad was there at Columbia, and probably some of my uncles as well. And so that concept we've known, and the way the face grows, the Harvold studies and the rhesus monkeys and Corcini and how our skulls have changed from the anthropological side. Yet this is literally hot off the press. Just the day before we recorded this in early November, I had someone contact me today that the British in Great Britain, the General Dental Council just ruled that it's official position now, that the only cause of malocclusion is genetics. And any dental practitioner or medical for that matter, I think, but for this case, dental, who even suggests that they can influence craniofacial growth may be accused of making false and misleading statements.
Wow.
I mean, like, this is, wow. I think about that, how just archaic that mindset is. So
terrible.
What is going on with that? Why? Because I've always said about on the extraction side, and I'd love to hear your thoughts on it. I always say, like, I haven't said that physically extracting teeth causes an airway problem. My point is the teeth are the symptom and you're extracting them because the airway problem caused the growth to be aberrant and deficient, and you're treating the symptom by removing the tooth mass. Right. And I mean, there's been Mills had studies in the 60s on this, and McNamara did a great study in the early 80s on this, showing that it's not big teeth, like almost never, not never, but almost never. It's almost always deficient jaw size. And so by extracting the teeth, you're treating the symptom. So why is that still such a hard concept for the dental community to accept?
Yeah, it's really interesting because it's not even like the data is not there.
Agreed.
Or the data is there.
Yeah.
There's many studies on it. There are papers.
Yep.
There are studies since I was a resident, scientific, with evidence that show that MMA is by far the most predictable and successful treatment for OSA. By far, more than any ENT procedure, more than anything. That was in the 90s.
Right.
That we knew this.
Yep.
There are many papers that say from the orthodontic literature that say removing teeth shortens the arches.
Yep.
Right. I think that's accepted.
Yep.
So it's like there's so much studies about MMAs and sleep apnea correction and airway and so on and so forth. So it's not like you can make that argument that we don't have the data. Where's the data? Because it's there. It's just that people are choosing not to look for it. I think everybody that says that where's the data actually has never even spent 10 minutes on PubMed looking for that data.
Yeah, or they're cherry picking one or two articles that say the opposite, that are very poorly done studies, like that Larson study from 2015, which was utter abomination. They're literally just, and they just clutch their pearls on these certain, and that's all they'll say. They'll just say, well, what about this? Or what about the AAO white paper in 2019, which I've gone into many times on this show, talking about some of the many of the inaccuracies with that. So yeah, I don't know why they're fighting so hard to, it's not really a hard concept. I mean, I don't.
And I agree with you. It's not, I think that there is this, I think part of it, because I got into this, I put a post on Instagram and TikTok about a year ago. I ended up taking it down because I was forced to take it down, about premolar extractions and airway. And what I was trying to say was exactly what you said, that it's not the act of removing premolars that I'm saying is causing the sleep problems, but it's the idea of missing the reason we're prescribing those premolar removals, meaning that the jaws are too small, and that small jaws are the cause of the airway problems. That's what I was saying. So I was trying to make a point that it's not when we say premolar removal, it's not the actual removal, but it's not identifying that the arch space is not only crowding the teeth, but it's also probably crowding the tongue and the nasal passages.
Right.
Which I still stand by that statement. But I got a lot of heat on that because I think what a lot of the community was hearing from their perspective was premolars that orthodontists are causing airway problems. That's not at all what I said. I'm just trying to say we should look at arch size and think about the consequences of that with airway, which I see. I do 1,000 cases. I see 1,000 patients a year. I do over 200 cases a year, and I mean it's unquestionable. The lives changed, and the airway is getting better, and we have sleep studies where the sleep gets better, and so on and so forth. So I looked into it at that time, and I saw the position of the AAO. I know the AAO has a position on premolar extraction and airway, and it's been a year since I looked at it, but it was making a point that premolar extractions, there's no evidence that say premolar extractions cause airway problems. But at nowhere did it even address, do small jaws cause airway problem? But I think that's a very important but very important nuance in this, especially for a community that's treating crowded dentition.
Yes, thank you. Yeah, and the fact that everything was about OSA, and they didn't. I mean, it is such a spectrum. Sleep disorders are such a spectrum. I mean, to just make this about, and I'll hear people in the orthodontic side say, if you don't show me a pre and post sleep study, even in a kid, and the changes in their AHI, then it's an invalid data. And I'm like, oh my gosh, they just don't even know what they don't know. And at the other end of this, what always gets me is at the other end of this, there's a patient and there's a human whose life is being dramatically impacted by the decisions we're making. And we're having these academic debates about this and not looking at, again, the real cause. I actually saw something you did and I love it. I might borrow it from you, but using the agricultural side. And if a tree is sick or you're having if a tree has a blight or an illness, you don't treat the leaves that are starting to fall off. You got to treat the root system, the tree. You've got to treat the problem. You can't treat the symptom. And it was so profound when I heard you say that, because I'm thinking that's like the orthodontic way, right? We're treating the leaves all day and we're trying to see who's a better leaf treater, like who can try to glue them on to look better and who can make them look. And yet we're ignoring the fact that's not the problem. And you go to orthodontic residency today and you look at the way these kids are being treated, and it's wait and watch and then start on later and then removal of teeth. And you're ending up with a lot of compromised results because you're trying to you're not normalizing anatomy. You're just trying to get a good occlusion. And it sounds like with what you're doing surgically, you really push the envelope and you're getting tremendous results from really normalizing anatomy. When Jeff Rouse was on a little while back, he was talking about the importance of that normalization of anatomy. And we were having a great conversation about that. And that's so true, because what you're really doing, the reason you're getting better results is you're getting more profound normalization and more stable normalization of the anatomy. And that's what it's about. And so now, did you So now as part of your intake, do you start to ask patients when they come, are they coming to you saying, doc, I'm here because I can't breathe, or is it both? And are the ones that don't come in knowing about an airway problem? What is your diagnostic protocol to get to the bottom of that?
Yeah, so it's interesting. I see the whole spectrum. I have people that have seen every podcast, have read every Reddit post, jog surgery group post, and they're very well educated, more than most doctors. And they come in here knowing they have an issue. And then I have people that have just their chief complaint is aesthetics. My jaw is too small, or my cheeks are too shallow. And then there's a group that come in with discomfort in their TMJs, their TMJ patients.
Okay.
Regardless, the diagnosis, the protocols are pretty much the same. We get a CBCT on everybody. On the CBCT, I have airway volumes. I have a vision of anatomy. Where is the tongue space? What are is there hypoplasia? Is there retrognathia? And then we have our clinical exam. So with our expertise, all of us as dentists, orthodontists, it's undeniable that with a radiograph and physical exam and history taking, that you can get a suspicion of a sleep disorder right away. So that's one component of it. And it's a huge component of it.
Huge.
The other component is I get a sleep study on almost everybody now.
Interesting.
Almost everybody. Because the truth is, and if you accept that our jaws are smaller now, which I do, because it's undeniable, the historic skulls have 32 teeth and they're straight, and their palates are wide and their jaws are stronger.
And almost no crowding.
So I don't think anyone can argue against me that's not true. Because now everybody needs braces. I think I saw papers where 90% of the population or more would benefit from orthodontia. Almost everybody I see has no room for their wisdom teeth since I was a dental student.
Have a lot had premolars out?
And a lot of patients have had premolars out, a whole lot. A lot of my patients with sleep apnea that come with sleep apnea as their chief complaint in their 50s, 40s and 50s have had their premolars removed. And I think I saw literature on this too. There was a boom in premolar extractions in the 70s, 60s and 70s. A boom. It's significant. It's an outlier. And so many of those patients that I see from that era that are now 50s, 60s have had their premolars removed, and they're suffering from sleep apnea. So, I mean, it's interesting. So a lot of people, whatever they're coming, even a TMJ patient, I used to dislike treating TMJ patients because as a community, we didn't know how to make them better, right? We were making splints. We were taking out the disc. We were repositioning the disc. We were doing arthrocentesis. We were removing the condyle. We were putting TMJ prosthesis. And nothing really was a great solution, or they all had the same outcome, actually. It was like 50% got better, or 70% got better, or not, no matter which one of those extreme or non-extreme things you chose. Now I love seeing TMJ patients because, and we're going to write a paper on this, every single one has a limited airway on their scan and a positive sleep study.
Wow.
Without exception.
Oh, please do publish that data. That would be so great.
TMJ patients. So it's completely changed how I treat TMJ now, because now we're identifying that, we're diagnosing the sleep apnea, and instead of attacking the joint, which is really just a symptom, just like the teeth are symptoms and high blood pressure is a symptom of something else, the underlying cause, the TMJ discomfort, pain, arthritis, inflammation is a sign or symptom of something greater. And in the last, I don't know how many years we've been looking at it, without an exception, they all have small airways. And then doing MMA on them, I have probably 100 or more cases where TMJ was their chief complaint, and I've done an MMA on them or jaw surgery. The symptoms always go away. Or if not go away, they always get better.
Now, are you doing anything on the transverse with a lot of these patients?
Yeah. I mean, the way I look at transverse is if they have a crossbite or if they're extremely narrow, then I like to favor a 3-piece segmental to get it at the time of surgery. There are some providers I work with who are very talented with MSC or MARPI. And I'm totally fine with doing that pre-surgery. But someone that has normal, a relationship between their mandible and maxilla in transverse and they're not extremely narrow, I'm not going to prescribe expansion on those. We're going to bring them forward and they do really well. So I reserve the expansions because they are with risk of marking out the risks of asymmetry and tooth loss and all that stuff. We see all those things.
Yep.
And same with segmental, there's a little increased risk. So I reserve them for cross bites and real narrowness. But otherwise, I prefer to do single piece and counterclockwise rotation forward movement, bring them in the AP position.
Yep.
Yeah. So now I'm under the philosophy that nobody needs a total joint replacement. Nobody. I think that nobody. I've had I used to think even, okay, maybe we'll reserve it for the ankylosis patients that had hypogenic ankylosis. Even in those patients, I've gone to gap arthroplasty, making room, getting rid of the ankylosis, and then doing jaw surgery to give them now a better airway, and they've had great success. And we've written that up too. So I think nobody should get a total joint replacement unless there may be very few reasons to do it, but it's a lot of metal. And for the most part, you're just trying to get them to open and close. But most of the patients that are getting this can open and close, and their underlying problem is airway. So to me, I think TMJ is a really interesting thing. And I think that's something where data will be important to make that point, but it's something that I see clear as day. And I've treated many patients successfully just by opening up their airways, getting their bites better, making them look better instead of attacking the joints, and then their joints get better.
Yeah. And as you're speaking, I'm thinking too, why are us orthodontists not hearing this and saying, wow, we're seeing people, and there's literature out there on this as well, but just hearing your stories of all of these patients, so many of these things we can fix when they're little and pliable and we can modify their craniofacial growth and development if we take the time to recognize the etiology and get at what's going on and work with our medical colleagues and get these patients the help they need. We can redirect this growth and we can stop these problems. I'm not saying in 100% of patients, but in so many who won't have to end up going through these. And the surgical procedure, obviously, is you've developed ways to make it work better. That being said, how many years of their life have they had to suffer? And the relationships that that they might have struggled through or lost, and the weight issues or health issues or occupation, I mean, all sorts of stuff. I mean, it's just really, it's really profound. And yeah, and I appreciate, that was a quick hour. I gotta say that was,
I feel like we're going another hour. Maybe we should do a follow-up on this.
I'd love to. Let's do it. Let's absolutely do it. Because I have some more questions I want to ask you, but I know you got a hard stop here to hop off. So let's plan that and hop back on. But no, I want to acknowledge you for what you're doing. What's that?
I would enjoy that too. I'm enjoying this conversation. So let's do a follow-up. We'll plan it.
All right, perfect. That sounds great. But before we hop off, I want to acknowledge you for what you're doing and appreciate your willingness to teach this and talk about this. And I know from being someone who's having to put myself out there, you take a lot of arrows, and it's really appreciated. And I value what you're doing for our profession and for our patients. And yeah, I can't thank you enough for that and for your time. And I look forward to part 2 for sure.
And that sentiment is mutual for sure.
Oh, thank you. Much appreciated. So Dr. David Alfi, awesome. Can't wait for the second part.
Yeah. Thank you very much.
All right, bud. Talk to you. All right, bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening. And always remember, you have been blessed with the ability to do amazing things.